All right, thank you. I hope you guys can hear me. I know this is always kind of weird giving these talks where there's just zero feedback. And so if anything doesn't come out right or if anyone has any concerns, just let me know. I want to thank Iramax for giving me the opportunity to talk today. Hope you guys are all doing well and staying healthy. I know it's been a crazy year, 2020, but hopefully it'll get better, and definitely next year is going to be a good year too. So I'm not exactly sure what was explained up front, but I work at Emory and I'm a plastic surgeon. I do mainly breast reconstruction. I do a lot of cosmetic breast surgery as well. And I was asked to talk a little bit about our experience with irrigants in breast surgery, because I think it really is an important part of what we do. Let's see. So I'm a speaker for RTI, which creates a human ADM, which I'm not going to talk about today. And then obviously I'm paid by Irrisept to give this talk. If you look at the statistics from the American Society of Plastic Surgeons, breast augmentation, 313,000, breast reconstruction, 101,000. That's a lot of implant-based procedures that are being performed in the US. And if you look at 80% of all breast reconstructions are implant-based. So roughly 80,000 breast reconstructions have been performed with implants every year in the US. And the reason that's important is because I'm going to talk, we use irrigants in breast augmentation all the time. I'm going to focus mainly on how we use it in breast reconstruction, just because the data there is a lot more impactful, just because the infection rate is unfortunately higher in the prosthetic-based breast reconstructions. Fortunately, it's not that high in breast augmentation. I'm going to show you this slide. As you can see, on the lady on the left has significant animation. She had a bilateral dual plane nipple-sparing mastectomy and implant reconstruction. So we went underneath the muscle. And then here's a different lady, and this is a couple of years ago, and now she had a same procedure with the reconstruction just put on top of the muscle. And I'm not sure if you guys are doing a lot of pre-packs or if you're still doing dual plane, but regardless, I feel like we all change our practice in attempts to improve outcomes and make the results better and the results safer as well. So my go-to these days is direct to implant. I use tissue expanders still if I need to. For example, if the skin doesn't have a good blood supply, or if a patient wants to be a lot bigger, or if there's potential for radiation. But my go-to really is a direct to implant. I feel the patient heals faster. I think their complication rates potentially less, and I think they get a nicer result, and also potentially just have one surgery. This lady had a bilateral pre-pack implant reconstruction. Occasionally, a lot of times we need, can you guys see my mouse when I point?
Yes, we do.
So you can see she's got some rippling there on the left, and a lot of times we go back and do some fat grafting. I think that gives you a very natural result. Another patient, she had a bilateral skin sparing mastectomy with the direct implant. We preserved some of the areola, took the nipple. One surgery, she had that type of result. And so, like I said earlier, everything we do, and I know you guys all do the same thing in our practice, is an attempt to improve outcomes, right? So we want patients to get less pain, so we go on top of the muscle. We want easier recovery. We start doing deep flaps. We start doing less pedicle trams. We start doing pre-pectorals, direct to implants, and we want improved aesthetics. A big one is obviously cost effectiveness. We want better patient satisfaction. We want our patients to be happy. When they're happy, we're happy. And so doing, we want to improve their quality of life. And another big one is reducing morbidities, and infection control is a huge one, just because it is such a major problem, especially in implant-based reconstruction, because these are two, actually, my patients who had direct to implant, and the left patient was previously radiated, as you can see, but they both got infected. And the consequences, if you have someone who gets infected are are unfavorable. So we really want to do everything we can to try to prevent infection. The incidence of surgical site infection, roughly I tell patients around 10%. And this was a study where they looked at 18,000. They had mastectomies and reconstruction, and it ranged from 1 to 35%. But on average, I think it's fairly reasonable to say the average infection rate is around 10% for implant reconstructions. And you get some early infections, you get some late infections, you get minor infections, you get major infections. And even if you do the tissue expanders, you still get infections at that second stage. So, that you're not out of the clear for infection, especially in someone who's been radiated when you go in and exchange for the implant. So, infection is something that I know we all think a lot about. It's not just that we don't like being called in the middle of the night because someone's not doing well. They can be expensive. This was a study from Penn where they looked at the cost of complications, and expander implant infections increased cost of care by $12,000. This was about 5 years ago. And if you look at that, and I wrote there at the bottom, if you have 80,000 reconstructions, that's 8,000 infections. If it's 10%, that's over $100 million a year. So the cost to the healthcare system of infections is really high. The infections increase reconstructive failure. We can sometimes salvage infections, and I'll discuss how we do it. Irricept's a big part of it. But patients with expander infections requiring unplanned reoperation had about a 50% reconstructive failure rate, which shows you that it's not 100%. Not everyone who gets infected has to get their implant removed. And getting some kind of a protocol going where you do irrigation and potentially antibiotics and things like that, you can often salvage infections, and it depends on the extent of the infection. And we'll talk about that in a little bit as well. And then obviously it's a big impact to the patient as well. So patients don't like getting complications. Patient satisfaction decreases significantly in people who, those who get infected. This was out of Boston, and the infectious complication after implant reconstruction was an independent predictor of dissatisfaction. And we're all trying to keep our patients satisfied for obvious reasons. Another big issue with infection, not only does it potentially cause your reconstruction to fail, but even if you do salvage that implant reconstruction, the incidence of capsular contracture will go up significantly. And it's not just clinical infections. Maybe subclinical infections are what contribute to capsular contracture. And I know all of us kind of struggle with trying to figure out how to prevent capsular contracture. So when we're going through our treatment and we're adjusting our technique, we're doing it in such a way that we're not just trying to prevent infection, we're trying to prevent potential long-term consequences of that, such as capsular contracture. And unfortunately, when you're putting in a foreign body, when you're putting in an implant, the risk of it getting infected is always going to be there, and it's an interaction between the implant, between the patient, and between bacteria that might be on the skin, that might be in breast tissue, that might come after the fact. And we not go. Right now, implants are all we have in terms of foreign body for breast reconstruction. So we're always going to have that host implant interaction. We need to figure out how to keep that annoying bacteria out of the picture and keep that infection rate down. We all know that the common culprits are the coags negative staphylococci, such as Staph epidermidis, Staph aureus. And there's certain factors that are in our control, and there are other factors that are not in our control. And those that are not in our control, things like patient factors, such as BMI. So obesity is a big problem in the US. Smoking, we definitely try to get patients to stop smoking, and this is not necessarily elective because they don't have a choice on needing a mastectomy. But we definitely try to get them off that. Diabetes, we try to control their glucose. Much better glucose control will significantly reduce your risk of infection. So in that regard, it is under our control, but the patient factor, it's not. And then with breast reconstruction, you have issues such as radiation, chemotherapy, all those things increase your potential risk of infection. You think of chemotherapy, you're lowering the patient's immune system. So, you know, their army is a quarter of the size. They're not going to do as well if they are vulnerable, such as an infection. And then skin flap thickness. When you have compromised skin flaps, the incidence of infection goes up just because that's going to be a very vulnerable location. So what's in our control? So we do have things that are in our control, such as temperature in the operating room, the number of people who walk in and out of the OR, anesthesia time. We need to all keep that down. Less traffic, shorter surgeries, keep the temperature up. That helps with lowering infection. And those are environmental. And then there's things that we do as surgeons. Sterile technique. We need to respectfully handle the implant. We choose our implants appropriately, whether it's the breast implant or whether it's the ADM or whether it's the type of drain you use. All those things we need to take into account. There's certain, I'm not sure if you guys use human ADM or ADM with your breast reconstruction, but certain ADM products have lower risk of infection just based on the sterility factor alone. So all that stuff is we need to take into consideration. And then things like hematomas. You know, we don't think about this, but if patients at a high risk of a hematoma, seroma, those are all things that that will increase the risk of infection down the road. And so what decreases infection? And that's pretty much what we're going to talk about. And I'm really going to focus on pocket irrigation, but there are a lot of things that we do, and I know you guys all do, in trying to prevent or minimize infection. You know, preoperative antibiotics, perioperative antibiotics. Most of the evidence today is saying that you don't need long-term antibiotics for prophylaxis. We do one dose pre-op, and we treat them for 24 hours afterwards, and then we stop. We don't wait until the drains come out. You probably can if you want, but the problem with antibiotics is all the drug resistance, bacteria and things like that. Changing gloves. You know, a lot of surgeons, before they touch the implant, will change the glove because they feel that they have clean gloves. They want to have a clean approach. Even double gloving helps, and there have been studies that have shown that double gloving will significantly reduce the incidence of infection. Minimal touch technique, we'll talk about that. I mentioned glucose control. We used to have a lot of sternal wound infections in Atlanta at Emory. The cardiac surgeons did two things, and now we hardly get any. One, they had much tighter glucose control. And two, every patient got pre-op nasal Bactroban. So that significantly cut down on the MRSA rate. And that in open heart surgery definitely helped prevent sternal wound infections. So I'm going to go through our protocol, and you know, I think regardless of what you do and regardless of what your protocol is, it's important to have a protocol because you know, studies have shown that if you can adhere and standardize a lot of what you're doing, you're going to do better. You're going to get better outcomes. We started this protocol about 6 months ago, and already you know, the incidence of infection has dropped down. One of my partners, Peter Thompson, as a quality control officer, and he's been looking at ways to reduce infection. So we've come up with this protocol. It's called the PIGS protocol, and I'll tell you why in a second. First of all, preoperative elements, daily showering with Hibiclens. Before that, for 5 days, we do the intranasal Bactroban for 5 days before the surgery. Intraoperative, we prep with ChloraPrep. There have been a lot of studies that show that ChloraPrep, which has a chlorhexidine base similar to the Irrisept, is significantly better at preventing infections. And when we're doing breast reconstruction, my residents will go in and prep the tape before the breast surgeon. So the breast surgeon doesn't prep anymore. We do the prepping. Strongly encourage double gloving. Draping, drapes are secured with staples. They then I-band strips, and this is all supervised by us. Tegaderm nipple shields for the nipple-sparing cases. Mark Codner, a good friend of mine, colleague, unfortunately passed this year, did a study looking at putting nipple shields on every breast augmentation case he did, and he found that about 1/3 of the patients, when he took the tegaderm off, or the nipple shield off, actually was positive for bacteria underneath it. So there is that endogenous breast flora that does sometimes come out of the nipple that potentially increases your risk of infection. Minimize oral traffic, and all the standard things that you guys do. This to me is actually one of the better things we do. And these tegaderms, it's a little bit of a nuisance to put on these IO bands, but it's so often when you just drape with towels and staples, before you know it, you're looking at the back of the bed and EKG leads, and this really prevents that. And anything you can do to improve that cleanliness of your site will help reduce your infection. So what about some of the post-incision elements? And this is where pocket irrigation is so important. And we've developed a protocol where we do thorough Irrisept pocket irrigation. We looked at all the other different irrigation types. We've tried triple antibiotics. We've tried phase 1. We've tried others. And looking at the evidence, we elected to go ahead and use Irrisept. It's actually what I've been using for the last, Sam, I don't know if you know how long I've been using it, but maybe 4 or 5 years. And we've had great results, and I'll show our study in a second. We fenestrate the acellular dermal matrix, and that helps with fluid going through it. We then soak the implants prior to insertion. We try to soak it on the back table for at least 5 minutes with Irrisept, and I'll show you some evidence as to why we do that. We change gloves. If it's pre-packed, we wrap it on the back table. And I also like to soak my ADM with Irrisept, and I'll show you some videos on that in a second. And then clean gloves. We try to clean gloves as much as we can and just prepare the field. And here's an example. Right before we put the implant in, we put tegaderm on the skin to try to minimize contact with the skin. You could use the Keller funnel or any other type of funnel. We did a study on Keller funnel, and it showed there's about a 30% decrease in contact with the implant and the skin. And the patients who had the Keller funnel were 2 times less likely to have bacteria on the implants. We looked, this was an in vitro study where we looked at, we did using cadavers and material we put on the skin, and it made a significant difference. So this is what we do. I know sometimes it's hard with mastectomies. And this is the PIGS implant kind of protocol. The P stands for pocket irrigation, I is implant has been soaked, and G, or the gloves, and then S is just really ensuring that we have a sterile field, because all that stuff is going to make a difference, and we're already showing in the preliminary data that it has. And then closing, we put a drain. We use the same drain. There are about 5 of us doing these type of surgeries. We all try to do the same thing with the same drain, the same type of closure. We use clean instruments for the closure. And then what I do, it showed earlier, we don't dwell. So we don't soak the Irrisept for 5 minutes in the pocket, although it would be nice if we did, but I think that would just increase the length of the surgery, and I tend to get impatient, so I don't do that. But what I do is, right before I'm closing the skin, I go ahead and I squirt the Irrisept into the breast pocket, and then I finish closing the skin. And by the time we get to the PACU, the recovery room, I go ahead and remove the Irrisept out of the drain. So in essence, it's been sitting there for about 5 to 10 minutes. And then we use a biopatch. Some people feel that the biopatch helps. Studies have shown sometimes it doesn't. You can see the biopatch here. I'm not sure if you guys have a biopatch. And then I really like this Tegaderm bra. I feel that this Tegaderm bra just prevents that rubbing of the skin, especially in the larger breast. So it's almost like mandibular maxillary fixation for mandible fracture. It's securing this immobile chest skin to the mobile breast skin. And I feel like the drains actually come out earlier, the patients do better. And especially with nipple sparing mastectomy, it keeps that nipple where you want it to be, so you don't have to worry about nipple malposition. I'm not going to try to say that in Spanish. Unfortunately, I'm not very good at Spanish, but the rest of them talks focusing on the whole irrigation factor. And I think it's really true whether you're sewing up a laceration in the ER, or whether you're treating a mesh infection in the abdomen, or whether you're even just doing putting in a total hip replacement. The solution to pollution is dilution. So if you can irrigate, that makes a big difference in just preparing that pocket and that wound and reducing that bioburden that might happen. And so when it comes to irrigations, really it's anything is better than nothing, right? So this was a study where this were mainly breast augmentations, but they looked at triple antibiotic solution versus control. And the infection rate was lower with the triple antibiotic solution. Same thing for Dr. Pfeiffer's study, where the infection rate was less when the triple antibiotic solution was used. This, as you know, is something that was popularized by Bill Adams, and he actually has his own, I forget how many steps in his protocol, but he also has a protocol, and I think it's important to use a protocol. We were using triple antibiotics. I think it's a little bit more cumbersome because you have to get it made. It's not ready to use. The potential resistance to certain bacteria if you overuse antibiotics, and I think bacitration was actually just taken off the FDA this year. Said it wasn't something that we should keep using, so it's not allowed by the FDA currently. So we're always looking for other alternatives to triple antibiotic solutions. There is a widespread prevalence of this resistance I'm talking about if you use multiple antibiotics, and if that happens, it just makes these antibiotics even more difficult to treat. So we try to minimize the use of antibiotics. There are antiseptic irrigants. Irrisept is one of them. You can see in the right low quadrant. The iodine is one. Iodine was also removed from the FDA, did not allow it. And then recently it came back on, but there's concern that it might damage the implant, so people try not to use iodine. Phase 1, let me see if I can go back. Hypochlorous acid is one that people talk about. We've tried it a few times. I haven't really cared for it too much. They're all biocidal, so they destroy and inhibit the growth of these microorganisms, whether it's bacteria, fungi, whether it's viruses. And the nice thing with these is really they have minimal toxicity, and they're not very irritating to the skin and other healthy tissue. Chlorhexidine gluconate, which is what Irrisept is, it's a very low concentration chlorhexidine, 0.05, and it's a cationic chlorinated bioguanine. Not even really that sure what that is. I know the scientists in the group can probably help out if people have questions. But it has a broad spectrum activity, and what it does is it destroys that cell membrane of bacterial species, and so essentially contributes to cell death. It's robust in its antimicrobial activities, and it's very gentle on native tissue. I think that's supposed to be yet, not yet, not yes. And the nice thing is that it comes ready to use. So it's quick, it's easy, it's off the shelf, and it's right there to be used. There have been some recent studies. This was from 2018, and they basically looked at this Irrisept concentration and how it prevents biofilm formation by MRSA. And biofilm is a big, it's a big catchphrase that we all like to talk about. And I think there definitely is something to it. You have to get something that penetrates the biofilm. And, this is obviously a product that has shown to reduce the formation of MRSA on synthetic meshes when compared to saline alone. So there obviously is some data to support its use. This is 2 other clinical studies. The first one was looking at loop ileostomy closures, which carries about a 31% infection rate if you just irrigate with saline. That can drop down to 4.8% if you irrigate with Irrisept. So a significant improvement right there. And these are things that have a high risk of infection, so it's easier to show an improvement. The same thing with pilonidal closures. 20% infection rate if using just saline, down to 6.5 when Irrisept was used. So, this to me is kind of a no-brainer. If you're doing a lot of these type of surgeries, you want to use something other than just saline to irrigate the wound and reduce your risk of infection. This was an in vivo model, but they basically intraoperative irrigation with that same concentration of chlorhexidine, and it was able to clear polypropylene mesh infections. Just a couple of weeks ago, I had a patient that had a previous mesh infection. A mesh hernia repair. She was infected. We took her back, opened the incision. She had purulence in there. Obviously, the stakes are high. I don't want to take out the mesh. I irrigated her with Irrisept, put another drain in, and she ended up doing well. If I'm really concerned, I irrigate the drains post-operatively with Irrisept. I didn't have to in her, and she ended up doing well. We cleared it with antibiotics as well as the Irrisept irrigation and washout. And we were able to salvage that mesh. So I think that's huge. This was from the website, and it looks at antibiotic irrigation. And the big question is, how long do you put it in for? Is it okay for a minute? You just squirt it in. Is 5 minutes better? Is 30 minutes better? And they basically show that there is improvement in the kill, the percentage kill with 5 minutes versus just 1 minute, which is why we do like to soak the implant beforehand for at least 5 minutes. And I like to soak the pocket afterwards, and I think that will hopefully increase the kill rate of this washout. So in my practice, pretty much every time I do a breast implant case, whether it's an implant exchange, a breast augmentation, tissue expander reconstruction, I wash the pocket out with Irrisept. I soak the implant with Irrisept. All the abdominal wall reconstructions, right before I'm closing the skin, I wash out the pocket. Anytime there's a contaminated wound, whether it's an infected knee or a joint or a back or something that we're doing, I use Irrisept. If there's a risk of infection, that's relatively high. So when we're asked to do a lot of scalp reconstruction and low extremity reconstruction with orthopedic surgery. This is so quick and easy, and I think it definitely makes me feel better, and I think clinically you get a better result if you're able to wash it out. This is kind of what I do, and you can see it's a very easy to use bottle. You can squirt it, you can control how much pressure you want to come out of the nozzle. I basically will soak that implant pocket with the Irrisept. We then suction it out, and you want it to be nice and clear. And what that does to me is it really reduces that bacterial load within the pocket, right? So my picture here, you wonder why I'm having someone cleaning my house. That's if my parents are coming. I want the house to be clean, right? Same thing, if I'm gonna put an implant into a breast pocket, I want that pocket to be clean. It's just gonna tolerate that implant so much better. And then the mechanical action of the Irrisept is fairly effective in loosening particulates and debris from the wound. So if you just think of an asepto syringe, how much, maybe 6 or 7 millimeter mercury pressure is squirting it into the wound. I don't know exactly what Irrisept does. Maybe some of the scientists or Sam or can let us know, but when you're pushing with that nozzle and you're delivering that pressure in a very controlled fashion, I feel that the pressure is greater than just a simple, squirting in with a septo syringe, and how it dislodges bacteria from the soft tissue and cleans up some of that debris, especially for chronic wounds, for burns, things like that. I think this makes a big difference. Another example, how, right before we put the implant in, we just irrigate that pocket. If it's a bilateral reconstruction, I will sometimes use just one bottle, 450 cc's, and we'll talk about that in a second. If it's unilateral, we definitely just use one. This reduces the bacterial load within the pocket. Like I said, it's cleaning it up. It's reducing that local microbiome. We know that every pocket has potential bacteria and things that can cause problems. And if you can eradicate those locally, you're going to have a much lower incidence of systemic infection down the road. Another picture I just took from the internet, you're about to go and cook your meal. Which kitchen would you rather cook in? Would you rather cook in the clean one on the right or the dirty one on the left? Same thing with implants. You want to put those implants in a pocket that is much more conducive to doing well. And I haven't seen any evidence on this, but I have seen it in my readings that some people feel decreasing that local biome with a pocket irrigant is even more protective than systemic antimicrobial prophylaxis. Like I said, that might be anecdotal because I haven't seen evidence on it, but I do feel like it is a very important part of what we do to try to control infection. And then I soak that implant, and this is easy to do. You usually pick that implant, you have the nurse on the back table, soak it for a few minutes. And like that study showed with adherence of bacteria to the mesh, this is going to diminish not only the seeding of bacteria, but also the adherence of bacteria, that helps. I use acellular dermal matrix products. The type we use is Corteva, and you can see it's very easy to just soak it in the package. I use Recept soaking it. It just makes sense to me. It doesn't destroy the extracellular matrix of the ADM at all. It still works great and potentially carries that antimicrobial component with it when we put it into the implant. You can see it takes about a minute, and it just kind of rehydrates that piece of cadaver skin. All right, so this is my little trick, and this is a gift to you because, I'm not as strong as maybe some of you guys, but occasionally it's a little more difficult, and the nurses have a hard time opening that cap. This is a very easy way of opening that cap. You just put an Army Navy on, and you just twist it. You can see it just kind of opens nicely. Sometimes it just gets slippery, and so we can't do it, but the Army Navy works great, and then you put the nozzle on top of that. That's a nice trick that we've started using. 450 cc's is a perfect amount. Like I said, for some of the bilaterals, we might open 2. Thanks for the feedback, Mike. It is hard giving these talks when there's just kind of no feedback. Maybe just having someone nodding their head every now and again lets me know that people are still there. So 450 cc's works great. This is a tissue expander I use. It has a dual port, so you can aspirate from one port, you can drain from one port, and occasionally with the tissue expander infection, you can see the drain there. That is how you aspirate, and then that is how you drain. So if you are expanding someone and you're worried about there being a fluid around there, this is showing you how you can aspirate some of that fluid around your expander. And so the same way, occasionally I will squirt in some Irrisept and irrigate out the pocket without having to go back to the surgery if it looks like there's clinical infections. This was a patient you can see had a dehiscence over incision. The implant was exposed. You always worry about that kind of thing. We just irrigated with some Irrisept and an implant exchange, and she ended up doing fine. We salvaged the implant. You hate to see this. The patient had a bilateral mastopexy aug. She had this purulent drainage. Basically opened her up, washed her out with Irrisept, and there she was, the next week. It was doing well, and she ended up getting salvaged. So for those of you who are going to start using this, how do you compare what you've been doing to what you are going to do? And I think it's important to decide what variables you want to standardize and what you want to change. So whatever you've been using for irrigants in the past, if you're going to start using Irrisept now is when you can kind of start collecting data, and I'll show you how we did ours. You want to try to make your groups similar, so do all your breast dogs, do all your tissue expander reconstructions. You want to define your outcomes, your comparisons for each group, and your power analysis. I'm not a statistician. There are other people who help with that, but we just try to get as many patients as we can. The more patients you have, the more power. And then define the outcome of interest. Are you looking at infection? Are you looking at wound healing, seromas, takebacks, revisions, capsular contracture? We look at all of those because some of them might end up being significant that you don't know about. And this was our study that we did last year, I think, yeah. And we compared implant-based reconstruction using triple antibiotics, which is what we used in the past, to low concentration chlorhexidine. And we basically compared the two different irrigants, and we looked at infection and outcomes. They were all the immediate reconstructions. The two groups were triple antibiotics versus the Irrisept, and we compared complications. One of the things that you need to do when you're looking at your two groups, and they asked me to talk with you about how you might want to set up a trial for yourself. You want to try to keep the groups as comparable as possible. If they're evenly matched groups, you're going to get a lot more out of the data, and it's just going to be easier to compare. These two groups, triple antibiotics versus chlorhexidine, about 350 patients in each. But you can see the radiated patients, the chemotherapy was a little bit higher in the triple antibiotic group for some reason. But that's okay, because you can always control that after the fact, and I'll show you that too. You can see I did a lot more direct to implant reconstruction versus tissue expander in the second group, and there was more there was more nipple sparing. Let's see here, yeah, more nipple sparing in the more recent group than in the control group. So those things that might change your risks, but they won't, and then you can control for those variables after the fact when you do your multivariable analysis. So the overall complication rate was about 27%. The most common complication was infection in our series, which was 9%. And here we're looking at any complication. The blue being the triple antibiotics was significantly lower than the infection. Any complication was lower in the chlorhexidine group. Minor complications were lower. Delayed wound healing was a little bit higher. Infection was significantly lower, 12% versus 6.4. Device failure was trending to significance in it being lower in the chlorhexidine group, and the same thing with capsular contracture. And I think if we had more patients, the low concentration chlorhexidine, which is the Irrisept, would probably be teased out to be significant in terms of improving capsular contracture and device failure. And this is what we did with multivariate analysis. So we basically controlled for some of those differences in the variables between the groups. And even when we controlled for those variables, the odds of any complication was decreased by 1.5 times in the chlorhexidine Irrisept group. So 1.57% lower chance of a complication. Minor complication was decreased by about 2.8% in the chlorhexidine group. And infection, obviously the big outcome of importance here, decreased by 2.5% in the chlorhexidine Irrisept group. So even if you control for the changes in the risk profiles between our two groups, the risk of infection was still less based on that one thing we did different, which was the type of irrigation we used. So, I think in conclusion from that study, the low concentration chlorhexidine, which is what we're using now, decreases complication rates. Obviously larger, more prospective studies are probably better, but this is the best data that we have. And I think what is a nice thing to do when you change something, it's always good to look back and tell whether you made a difference by changing or not. If you didn't, you might want to change back. But if it improves your outcome, then that just validates your change, and it's good to know. We did a similar study. This was a systematic review on breast irrigation in implant-based surgery. This is being published this year, but it basically looked at different types of studies like ours, which is this one, where we showed chlorhexidine having a lower infection rate. Haynes, similar study, showed chlorhexidine and triple antibiotics being similar, but when you added chlorhexidine to the triple antibiotics and you used both, their infection rate was less. And then some of these other studies with iodine and betadine and triple antibiotics. But basically what the take-home message from this paper was that the data suggests both, chlorhexidine, which is relatively new to the market, as you know, and triple antibiotics, which has been around for quite a long time. They're both very effective in protecting against infection. And so for the kind of the new player on the block to come in and stand up against the tried and true, which has been the triple antibiotics, that speaks volumes to the efficacy of these products. And, if it's less expensive, ready to use, less downside, it makes a lot of sense for both breast reconstruction, which carries a higher risk of infection, and even breast augmentation, where even one infection is too many. So, in conclusion, I think it's important that whether you use this irrigation or not, that you try to standardize a protocol. I think a lot of studies have shown that if you come up with a protocol and you do it the same way every time, you're going to improve your outcomes. And in this case, I think it's important to improve infection. In our experience, the use of this low concentration chlorhexidine irrigation is safe, and it's been very effective. It's quick, it's convenient, it's easy to use. The nurse I don't even ask for it. It's always on the back table, it's on my tray, and when I need it, it's there, and I squeeze the bottle and I control how much pressure, I control how much volume. It can be used prophylactically for pocket irrigation, implant soaking, and it can also be used for salvage situations where I'm worried about an implant infection, and I'm wanting to try to salvage the implant. Definitely use something in that situation as well. So hopefully that I think that wraps up my talk, and I think that's about an hour. We've been real happy with it. I'm happy to answer any questions that you guys might have. I think they were going to type it in, and just let me know. So thank you.
Thank you very much, Dr. Losken, for this amazing presentation. So now I'm going to start opening the Q&A session. Let me just check if we have any questions so far. Muchísimas gracias a todos por conectarse a esta plática. Ahora vamos a empezar la sección de preguntas y respuestas. En caso de que tengan alguna pregunta sobre, una pregunta para el doctor sobre ya sea alguno de los estudios clínicos que vieron, sobre la técnica quirúrgica o sobre el uso del producto Irrisept, adelante. Pueden mandarlas ya sea al chat de la ventana de Zoom, o pueden colocarlas en la sección de preguntas y respuestas. Voy a dar unos minutos para recibir si en caso de que haya alguna pregunta. So Dr. Losken, I'm going to give just a couple of minutes just to see if there's any questions, so they can get the questions to me, so I can ask you those questions so you can live answer them.
Okay. Out of curiosity, what type of irrigations are people using there currently?
Ok, si nos pudieran ayudar comentándonos el tipo de irrigación que utilizan normalmente en sus cirugías, para comentárselas al doctor. Okay, we have some people that say that they use triple antibiotics. most commonly? Okay, I have a question here. It says, what were your observations with the use of phase 1? You say you did not like it.
Yeah, I mean, I felt that it was not very much volume, so I didn't feel as though I was doing that much with it. I really liked the amount of volume that you can irrigate because, as I said, the solution to pollution is dilution. So, you know, even though chlorhexidine is low concentration, it has a fairly high volume of saline and irrigation, sterile saline, and so I think that made a big difference. You know, I've looked at some of the data with phase 1, and there's really not a whole lot of evidence out there right now in terms of breast surgery. I think there's more data to support the use of chlorhexidine, you know, I don't have any other reasons why, but you know, I just felt more comfortable with Irrisept, and you know, I like to try different products because I think it's important to see what else is out there, and then you just kind of go back to what you feel most comfortable with.
Perfect. Thank you very much. I have another question here. It says, how much better is the outcome you get using Irrisept when you use a cellular dermis for breast reconstruction?
Yeah, so I mean, some of that was based on let's see, I'm gonna guess 66. 1 second, I'm trying to pull up a slide. And I'll talk to that in a second. So, yeah, I mean, every breast reconstruction we use ADM, whether it's dual plane or whether it's pre-pack. I think ADM is one of those things that gives us more control in our reconstruction, and I think gives you a better result and allows us to do pre-pack, but it does potentially increase your risk of complications because it's another foreign body, at least initially. So, you know, when I want to use something like ADM because I like my result better, I have to do, it's even more important that I do what I can to minimize infection. So, you know, I find that using, and you can see here with using Irrisept and ADM, which all these cases had, all these, that 13% and the 6.4%, using Irrisept, I had a much better outcome when we were looking at infection with ADM. And, you know, that was controlled for even with some of the differences in the group. So, like I said, for every reconstruction, I use ADM right now when I use an implant. And because of that, I use Irrisept to try to minimize infection.
Okay, thank you very much. Recuerden que también pueden hacer las preguntas en español si es necesario y se las traducimos al doctor al momento de hacer la pregunta. So, doctor, I have another question here. If the breast implants are hydrophobic, does soaking it in the Irrisept really help?
The breast implant?
Yes.
Yeah, I mean, I think it just kind of creates an environment and it has less adherence potentially of bacteria. The same, you know, some of those data on mesh, if you just irrigate the mesh with some type of antimicrobial, there's a lot less likely for bacteria to adhere to it. And, you know, I hear what you're saying with it being hydrophobic, but, you know, you still are soaking it in. It's not necessarily going to carry the Irrisept with it, but I think it's going to, you know, by having the Irrisept on it, reduce the adherence or the potential seeding of bacteria. I don't know if they've done studies on that with implants, but like I said, I know they've done it with mesh, and I don't know if they've done it with hip replacements and that type of stuff. I vaguely remember seeing some, maybe Mike or Sam could talk to that, but I think it just kind of, it doesn't hurt the implant. So, you know, it can only help.
Thank you. I have another question. Does it cause any delay in this scarring process?
Don't know the answer to that. It definitely doesn't delay it. Does it improve it? I don't know. I haven't looked at that specifically. I think it's really hard to look at that because I'm not sure how you would measure those type of endpoints. I mean, capsular contracture is one type of scarring, but in terms of closing the incision, it doesn't delay the healing process. If anything, it might improve it if it cuts down on infection. But I don't know any data in terms of whether it improves wound healing. I know the safety data that I looked at briefly with Irrisept showed that it was safe and there was no tissue toxicity with in terms of the skin. But apart from that, I don't know.
Thank you. I have another one. Is the price difference using Irrisept versus triple antibiotic really impact your overall cost?
I'm going to ask the representatives talking that because I really don't know much about the pricing. But looking at this slide right here, if I'm able to cut my infection rate down, the overall cost to the hospital with infection, if it is around $12,000, is significantly reduced. But in terms of the actual cost to the hospital, in terms of using Irrisept versus triple antibiotics, I don't know. If anyone has the answer to that, feel free to let us know.
Thank you. I have another one. Do you recommend to irrigate with the solution other types of prostheses than breast, other than breast?
Sure. Yeah. I mean, anytime there's a foreign body in there, I'm going to use some type of irrigation, whether it's a mesh for ab wall or a hip replacement or infected hardware on the spine or the leg. I always irrigate out with some type of irrigant, and these days I'm using chlorhexidine. But yeah, it's not just breast implants; it's any type of implant. Just because the risk of the infection consequences are so much higher if you have a foreign body, and I'm doing everything I can to try to prevent infections in those patients. And this is just one of those things that we do that helps.
Perfect. I have another one. What is the effect on biofilm, specifically the kinetic time kill on Ralstonia piquetti, which seems more related to biofilm and ultimately breast contracture?
Yeah, I mean there is information on the website, and I looked at it previously, and I think it's around 50% with Ralstonia. But there is penetration of biofilm with that specific bacteria, and I think the longer it's soaking, the better it does. But it goes based on that website, and the representatives can let you know where that is. But it basically looks at all the different types of bacteria, and Ralstonia is one of them. It's most of it's 99%, 100%. But I think the Ralstonia was around 50. But all that information is on the website. I don't have it in front of me.
Thank you. Are you currently doing randomized trials with Irrisept and breast implants, either cosmetic or reconstructive?
No, I'm not. I should, and I wish I could. It's just so hard to do randomized trials. As you know, these days it's almost, it's just a lot of time, and you'd have to get quite a few numbers to do breast augmentation randomized trials because the infection rate is so low. Prospective randomized trials for breast reconstruction with Irrisept would definitely be interesting, and I'd love to see some. We're just not doing it.
Okay, thank you. Do you use drains on the cosmetic augmentations? And if not, how long do you leave the Irrisept in the pocket?
Yeah, good question. So I don't use drains on cosmetic breast dogs. I don't do that dwelling like I did with the implant reconstruction I told you about. What I typically do is I'll leave a little angiocatheter in the breast and that I put in, I close the incision, and then I inject some local, and then I pull out the angiocath. So that's what I do with the breast dog. The pocket I just irrigate with the Irrisept. I don't leave it in when I'm closing like I do with the breast reconstruction, just because I'm not using drains.
Okay, thank you. Another one. Do you use can Irrisept be used on abdominoplasty and facelift?
Sure. Yeah, I mean you can pretty much irrigate anything with it. I don't tend to irrigate my facelifts because the infection rate is relatively low, and so it becomes one of those things that you could definitely do it if you want to, but I don't feel as though I don't feel as though it's warranted because it has such a low infection rate. And abdominoplasties, I do irrigate out before I close. I often just irrigate with saline. If I've done a breast dog at the same time and I have some Irrisept, I'll use it, but I tend to not open it just for standard abdominoplasties. Now, if I'm doing an abdominoplasty and I put a piece of mesh to close the rectus, to reinforce the rectus, definitely in that situation, I'll irrigate out with some Irrisept because I don't want that to get infected.